Do you know there are several small hormones in our body which not only dictate our life, but they will also ensure what we are going to be and what we are going to do in our life. To talk about this, we have one of the best and top endocrinologists of Baghdad with us, Dr. Abbas al-Musawi, who has dedicated all his life till now in the service of humankind. He has been the guiding torch for several medical students, and he has been the integral part of so many patients of not only diabetes but hormonal imbalances also. So he has been the great personality in the field of endocrinology. He has delivered several lectures not only in Iraq but also in the many international forums. So we have with us one of the most respected doctors of Iraq, Dr. Abbas al-Musawi, and we are really thankful to him for accepting this invitation of discussion for the patient management and how the patient should manage their diabetes or hormonal imbalances in their day-to-day life. Thank you very much, sir, for accepting this discussion.
Thank you for your kind introduction. Thank you.
So, sir, starting this conversation further, I am really curious to know that how is your journey till now? How you have started your journey as a doctor? What was the thing which guided you or provoked you to become a doctor, and especially the endocrinologist?
Regarding endocrinology, I have this interest since my early years of graduation, probably in the second year of medical college. Physiology of endocrine system have attracted me really, and at the same time biochemistry is very attractive for me. And one of the main things that appeals to me is the fact that the replacement therapy in patients with endocrine diseases, I don't mean diabetes, for example, hypothyroidism, hypopituitarism, their replacement therapy is very fruitful. For example, those people with hypogonadotropic hypogonadism who are infertile, when you start gonadotropin, it was very fruitful, they become fertile. So it's an achievement. So although most of the endocrine diseases are not curable, but they are treatable.
Correct.
And one of them is diabetes, and as you know, diabetes is increasing in the globe in general. Yes.
Very high. Nowadays, whenever I see in my family members, I see there are diabetics. It has exploded like anything, the this disease, what we call diabetes. So, sir, what was it like doing your endocrinology training in Iraq? And did you also have exposure to training or conferences abroad?
Yes. My training really in Iraq, I have spent years and years in the Rashid Military Hospital in the endocrine unit, supervised by very elegant endocrinologists at that time. Regarding attendance of conferences and training, I used to attend probably more than 10 conferences per year during the preceding 25 years.
Okay.
And I am eager really to attend the upcoming conferences monthly, probably.
Yeah. Very good, sir. So, sir, which mentors or teachers most influenced how you treat people with diabetes today?
Probably in these days, one of the major attractive person in the field of diabetology is DiFranzo.
Dr. Ralph DiFranzo.
DiFranzo, he is very brilliant physician, brilliant endocrinologist, and he used to treat diabetes in a multifaceted fashion.
Correct.
Really. He targeted the pathophysiological changes rather than going through one path.
Correct.
He is looking at this octet, ominous octet, and he treats the patient accordingly.
Correct, sir. So I have also I also have the influence of Dr. DiFranzo by reading the mentioned article of you, that ominous octet.
Yeah.
and he is truly brilliant. So very means the personality is great.
Yeah.
So, so on a typical clinic day, sir, now coming to your day-to-day practice, and I'm sure every day as we see from morning to evening, there are several patients come to your clinic. So on a typical clinic day, what kind of diabetes patients do you see most often, sir?
Really, in our daily practice, I used to see patients with type 2 diabetes. So 50% of the patients are diabetic, and 50% have got different endocrine diseases. The commonest is probably thyroid diseases.
Okay.
Regarding diabetic patients attending my clinic, or probably if I used to see 100 patients with diabetes, 90 of them are type 2 and the others are type 1.
Okay.
But sometimes we come across other types of diabetes, probably gestational diabetes, LADA. Yes, we come across these types of diabetes.
Correct, correct. So, sir, as you have seen multiple countries and so many different people you have met, I'm sure you are in contact with doctors of many other countries also. But in Iraq, what is so unique about treating patient of Iraq means who is suffering with diabetes compared to the many other type of countries where patients are all there, but their treatment versus Iraqi patients' treatment of diabetes, do you find any difference?
I think the main difference is failure to inform the patient about the goals or the targets of treatment. A huge number of patients in our country, in Iraq, I mean, their main goal is improvement of symptoms. And as you know, symptoms may improve spontaneously. So the patient is complaining from polyuria, polydipsia, increased weight loss, for example, probably in hypercatabolic state. But such symptoms may be ameliorated spontaneously, and therefore the patient is happy. We have to inform the patient about the goals. And the main defect in our daily workup is the busy clinics. So, and the absence of educator. These are the main obstacles in our daily practice. We have to have an educator or social worker that inform the patient that the goal of treatment is not only amelioration of symptoms. The main goals are achievement of the targets in order to prevent the upcoming complications.
Correct, correct. I have seen patient of diabetes suffering with so many complications. So, sir, what are the most common question patient ask you when they first hear you have diabetes? This is a very important part of anybody's life when they come across, when you tell him now you are a diabetic person. So how this person reacts that time?
The reaction of the patients is quite different. Some of them accept the problem, and some of them may reject or deny the problem. They deny the problem. But I think that the long duration of experience, probably in the preceding 40 years with diabetic patients, I have developed a methodology just to convince the patient and to make him relaxed to accept such diagnosis. So I used to tell the patient that don't worry, the problem is treatable. We can control the situation slowly. There is no need to worry. And by optimal treatment, we are going to prevent the complications. So therefore, I think the method of the treating physician by using his skills is going to be very useful for the patient to accept this new diagnosis.
Correct, correct. Sir, I have seen one more type of patients who are always carefree. Like I have diabetes, but sweets are not harming me. And what happens? They will just keep on not taking the advice of the doctor, keep on eating the junks, and suddenly they will come and say my sugar levels are high. So how you tackle these type of patients?
These types of patients, I used to talk with them extensively. I spent time on time. That currently the high plasma glucose is not harmful. You feel nothing. And I tell the patient that in the waiting list of patients out of my examination room, people may have plasma glucose approaching 500 and they are not complaining from anything.
Correct, correct.
They are healthy, they are looking healthy, but the complications are coming. And my target or my task is to prevent or delay the development of complications. And such action, prevention or delay of complications is feasible if you accept or you stick to my instructions probably regarding diet, compliance with food, compliance with treatment, compliance with exercise, so on and so forth.
Correct. So there you may be coming across to the patients who might be asking, is my diabetes is curable or will I have it for life? So
This is the most difficult question, really.
yeah.
And I used to tell the patient that there is no need to be anxious. There is no need to be gloomy. It is not gloomy. And I used to tell them that 50% of patients with diabetes are not aware of being diabetic.
Correct.
So, for example, in Iraq, we have probably 2 million diabetic type 2 diabetic patients. 1 million is aware of being diabetic, and the other million is not aware. So you are lucky. We catch the problem early in order to prevent complications. There is
Correct.
no need to be anxious or looking to the future in a gloomy way. Yes.
So is it very important to catch them early, sir?
Yes, that's why we try to screen people with diabetes, even if they are not symptomatic, at the age of 35. For example, this is universal screening for every patient to check his fasting plasma glucose. But when the patient has got, for example, he is overweight, he is obese, strong family history of diabetes, previous story of gestational diabetes, dyslipidemic patient, we have to screen for diabetes on the spot at the moment. There is no need to wait to the age of 35, probably even at the age of 20. You may screen if the patient have got other risk factors in order to catch the disease as early as possible.
So, sir, you mean to say there is no minimum age for type 2 diabetes?
In these days, there is a sort of change. Probably previously we used to say that type 2 diabetes is at the age of 40. But nowadays, the disease is creeping, for example, to early 30s. And sometimes the disease in these days is creeping to early 20s and even in adolescents.
My God.
We used to see type 2 diabetes in children. And this is really, in the preceding 20 years, we used not to see children with type 2 diabetes.
Okay.
But nowadays, we used to see children at the age of, for example, 15 years, they are obese and they have got signs of insulin resistance, for example, acanthosis nigricans. So we are dealing with type 2 diabetes. This is something new, really, because of a change of lifestyle of people.
Okay.
Yes.
Means this is a new big information which I got. Means like you said, even the 15-year-old is now suffering with type 2 diabetes, because earlier I have read that in the children type 1 diabetics happens, but today we are fortunate to learn this new thing, that even now if the signs and symptoms are there, even at the age of 15, then one should go for the checkup. So, sir, what do you suggest? Do we go, even children, should we do the annual health checkup?
Up to the minute, the ideal age of screening is 35 years.
Okay.
But when a patient come with other comorbidities or risk factors, we try our best to screen as early as possible on the spot.
Okay. So, sir, you may be coming across with some patients who might be saying, why this happened to me? Why me only?
Yes.
Is it because of sugar? Patient might ask you, is it because of sugar or stress? But how to tackle this type of patient? Like?
Yes, I used to tell them that the disease is increasing. The prevalence of all non-communicable diseases is increasing globally, all over the globe.
Okay.
Some of them are genetic and the others are environmental. For example, the westernization of life, the use of cars, the use of elevators, lifts, rather than the use of stairs,
Correct.
lack of exercise, the type of diet, westernization of life. These are, all of them collectively result in a marked increase in the prevalence of type 2 diabetes.
So what simple way you use to tell to your patient of diabetes that in future they may, if they don't control their diabetes, they may suffer for kidney disease, eye problems or heart problems. So what is the ideal way to let them know that they have to control?
Yeah, I have to talk with them in a friendly way. It is not just a relation of a doctor with a patient, doctor-patient relationship. I have to deal with them as if I am their friend, and I try my best to prevent the development of complications. I tell the patient that don't worry, just stick to my instructions, and it is my duty to prevent the development of complications. No need to worry at all.
Correct.
And
So
I can convince them really.
So, like I got your point that this is very important for patient to be, and for doctors also, to be friendly with each other.
Yeah, the relation is not military.
Correct.
It is not military relation. And even the gestures, my gestures, I don't use this gesture, for example.
Correct.
Don't eat. Don't. I avoid this methodology of negotiation. I used to talk to the patient in a friendly way that my task is to prevent the development of complications. And I am sure that I can prevent these complications if you follow these instructions, and they are simple. So don't worry. So I talk with them not in a way of doctor-patient relationship, as if we are friends.
Lovely, sir.
Lovely, yes.
This is a very nice thing I heard, and I know you, what the feedback I have from several patients, that you becomes a very good friend of the patient. That is why they are very open to you. I don't like to take the names, but I have seen doctors who are always in hurry. Just let the patient come, prescription and go.
Yeah.
So this is the great thing about you, that your patients love you because of this gesture. I'm sure you have made lot of good friends. Your patients must be great friends of yours.
Yeah.
One more thing, because doctors are asking regularly for the patients to do their lab reports of diabetes. So what is your what you suggest your patient to focus maximum? Is it HbA1c? Is it fasting blood glucose or postprandial blood glucose?
Really, there are three pillars: the fasting plasma glucose, the postprandial one, and the glycated hemoglobin. Previously, for example, 30 years ago, people are concentrating only on the fasting plasma glucose, and they used to neglect the postprandial glucose. But I used to give the patient a table, simple table, that my goal, for example, is a fasting around 1:30, for example.
Okay.
2 hours after meal, whatever the meal is, my goal or my target is around 180, 170. So try your best to check your plasma glucose. In type 2 diabetes, twice per week is enough to check there by the use of finger stick.
Okay.
I try my best not to augment the problem. I try to simplify the problem. There's no need to worry. When your plasma glucose after lunch, for example, is approaching 160, this is okay. There is no need to worry at all. So I concentrate on the three.
Okay.
The fasting plasma glucose, postprandial glucose, and the HbA1c.
So all three are important, you are saying. Fine. So fasting, so if you can give some numbers that how much should be the fasting for the diabetic population, how much should be the fasting, how much should be the postprandial, and how much should be the HbA1c if the person is diabetic?
In Iraq, we have created a consensus of treatment of patients with diabetes, and the goal for most of the patients around 7. But this is modifiable according to the status of the patient. For example, elderly patient with comorbidities and limited life expectancy around the age of 80, for example, I have to relax. There is no need to be very stringent. For example, I may accept an HbA1c of 7.5 or 7.6.
Okay.
But for a young boy, for example, or young girl around the age of 18, no. I have to try my best to reduce HbA1c down to 6.5, for example, because this patient have got healthy nerves, healthy vasculature, and I try my best to protect him. And he can withstand, even he can withstand hypoglycemia. For example, an elderly patient around the age of 80 cannot tolerate hypoglycemia. So I have to relax. So these numbers are modifiable according to the status of the patient.
Okay.
Sorry. بس حابب نقرا الرقمات دكتور.
Okay.
So sir, one of the biggest question is, doctor, what should I eat? What should I avoid? And how do you simplify this for newly diagnosed diabetic patients?
Yes. The diet is really, restriction of diet is a major trauma for the patient with diabetes. Therefore, I used to use what is being called my plate.
Okay.
So my plate is a small plate that contains everything: carbohydrate, protein, fat, dairy products, and even fruits. But in a limited way, I reduce the portion, just reduction of the portion, but I ask the patient to avoid, for example, the use of simple sugar, sweets, for example. But I used to tell him that you can take fruits in a limited way with exercise, because diet is really, restriction of diet is a major trauma for the patient.
Yeah.
So therefore, you have to talk with them, as I've said, in a friendly way and simplified way. And I tell them that no need to worry, your plasma glucose will drop definitely.
Correct. So I have seen the patients that some of them, they say, I will not eat fruit, I will take the juice.
No, juice, taking juice is a bad habit really, because the preparation of the juice is going to destroy the cell wall of the fruits, and destroying the cell wall of the fruits makes the what type of sugar, whether it is glucose, fructose, or sucrose, any type of sugar in the fruits, it may result in severe rapid hyperglycemia, and very high glycemic index. So I tell the patient, you can take the apple rather than the juice of the apple, because the apple contains fibers, for example, pectin, for example. We need everything in the apple rather than only the sugar. So try your best to avoid the use of juices, and you can take the fruit itself.
Okay. So direct taking juices is not good for the patient, versus the having whole fruit is good. So any fruit which is good for diabetes management, or all, like I have seen people, they say that if I am diabetic, I cannot have mango, I cannot have grapes, which are fruits which are sweet.
No. Fruits, we used to take what's being called the exchange of carbohydrate. So the exchange of carbohydrate is around 15 grams of carbohydrate. For example, and one apple contains 15 grams of carbohydrate. It represents one exchange.
Okay.
And one orange contains one exchange, for example. And for example, 3 dates represent one exchange. 12 grapes represent one exchange. I tell them you can select anyone, no need to worry.
Wow, this is a very good thing for the diabetic. Like doctor has just tell us that they don't have to say stop to the fruits. Rather than stopping, they can have the fruits as suggested by Dr. Abbas right now. This is very lovely information.
Yes. I tell them that these fruits are interchangeable.
Okay.
No need to worry.
Correct, correct. Great, sir. There are some traditional fruits also, traditional food what people take in Iraq, like rice, bread, kebabs, stews, sweets. With practical changes, do you recommend, instead of saying stop, like nowadays they feel rice is a poison? Is it so? Because it's full of carbohydrates, they have to stop it?
We try to reduce the intake of carbohydrate, as I have said. For example, 3/4 of rice, cooked rice, for example, is equal to half sammoon, for example,
Okay.
15 grams of carbohydrate. So they are interchangeable at the same time.
Okay, so you are recommending instead of rice, they can have fish.
No, fish protein. Fish is protein. We are talking about carbohydrate.
Okay.
So the carbohydrate are exchanged, are subdivided into exchanges. For example, half sammoon is equal to 3/4 of cooked rice, for example.
Okay.
Both of them contain the same amount of carbohydrate. So they are interchangeable. So that's the list I tell the patient of carb exchange, and you can select anyone, and they are interchangeable.
Interchangeable, correct. So instead of having boiled rice, they can use the suggestion what you have just let us know.
Yeah.
Fine. So these are lot of learnings I am also getting right now. So I'm sure, I don't know what people are going to do, but I am definitely going to make these changes in my routine, sir. So how do you advise patients who eat late dinners? I mean, suppose whatever you have advised they are taking, but they are taking dinners very late. Sometimes heavy restaurant meals, they will say, oh, this is occasional, I am taking once a week or once a month. Or fast food, somebody may say, I have not eaten whole day, but I am in hurry, let me pick up a burger and it will be it. They are always in hurry. So how to deal with these type of people?
I used to tell the patient to avoid these habits. I ask the patient to try their best to avoid these habits. Fast food results in obesity, dyslipidemia, and worsening of hyperglycemia or glycemic status. And therefore, I ask them just to try your best to avoid fast food.
Okay.
Late dinner is really a very bad habit, and in these days we used to see in Iraq, probably in other countries, marked decrement in sleeping hours all over the globe. There is a reduction of sleeping hours all over the globe, and the sleep is very essential because, as you know, reduction of sleep hours may result even in development of non-communicable diseases. So I used to see patients, particularly in the preceding 6 years in our country, in Iraq, there is marked reduction in sleeping hours, and poor quality of sleep because of late dinner. Poor quality of sleep, as you know. And at the same time, it may have got an impact on the fasting plasma glucose. So measurement of fasting plasma glucose is not real because the patient is not fasting for more than 8 hours up to 12 hours. He's eating late. So therefore, these habits have to change in our country. But changing these habits is very difficult, really.
So, sir, how many hours a person should sleep, and before sleeping, how much should be the gap between the dinner and sleep?
The stomach is expected to be empty of food within more than just 2 hours.
Okay.
2 hours. And the ideal time of sleep is around 7 hours.
7 hours.
So 6 hours, when the patient or the person sleeps for just 6 hours, he is complaining from sleep deprivation.
Okay.
Yes.
Sir, what is the symptom of sleep deprivation?
The symptoms of sleep deprivation, some of them are visible and the others are not visible. The visible ones, for example, daytime sleepiness, anxiety, fatigue. Yes.
Okay. Just for the understanding, sir, there are people who sleep, suppose 1 a.m. and they sleep for 6 hours, or there are people who sleeps at 11 p.m. and they get up at 6 a.m. So what is only number of hours of matters, or the time of sleep also matters?
The duration of sleep is extremely important, and the quality of sleep is important. And you know, the physiology of sleep is affected by sunlight and affected by dim light.
Okay.
So it has got an effect on the level of melatonin and on the level of orexin. These are biochemical terms. So we advocate normal sleep as much as possible.
As food is a very nowadays a trending topic, there may be patients coming to you who will say that they are on keto, intermittent fasting, or low carbohydrate diets. So these people might be suffering with diabetes. So how do you decide what is the safe way and what is the most appropriate diet plan? Is it keto? Is it intermittent fasting? Is it low carbohydrate diet?
Probably low carbohydrate diet and Mediterranean diet.
Huh.
Our usual diet previously before the Western lifestyle appear in our society. The usual normal Mediterranean diet. It was really the best. Intermittent fasting in patients with diabetes may be harmful in a way or another because they are taking oral agents, for example, sulfonylurea, and we may expose the patient to the risk of hypoglycemia.
Okay. So I have a friend, she always says that she is doing intermittent fasting and she is feeling better, even though she is diabetic. She is on medication, but I don't know from where she has got the idea that 8 hours in the fed state and remaining hours in the fasting state. Is it good strategy?
If she can cope without any risk of hypoglycemia, there is no problem.
Okay. So having long hours as fasting is no problem for the diabetic as long as person can avoid the hypoglycemia. Fine, this is very good information because nowadays a lot of the trending is intermittent fasting. So many apps I am seeing online, they say do intermittent fasting, you will gain success, lose weight. Like there are some realistic weight loss goals and there are some opportunistic or very aggressive weight loss goal. So sir, how do you decide in a person that how much is the ideal weight and how much a person should lose in a month to be healthy?
The rapid reduction of body weight is not acceptable. So probably a reduction of body weight, for example, 0.5 kilogram per week is acceptable, but rapid reduction of weight is not acceptable totally. So there is no need to be in a hurry.
I have seen people boast, I have lost 10 kgs, I am great, I have lost 10 kgs in a month. So is it the thing of acceptance or you have a suggestion for him?
No, rapid reduction of weight by the use of, for example, limitation of the drastic limitation of diet. For example, the use of very low caloric diet. For example, 600 kilocalories per day. This is a harmful way. But in these days, we used to use medications. For example, SGLT2 inhibitors, for example, GLP-1 agonist for weight reduction. The patient may lose weight dramatically and rapidly.
Okay.
And this is really feasible. There's no problem.
Sir, since you have just mentioned about the medicines, I have seen there are a couple of medicines have come into the market. They are calling the semaglutide or tirzepatide, and they are saying they are magic to reduce weight. So can anybody use it, or it should be used only for diabetics, or means what you will suggest to the people?
Now these drugs are approved for obesity. At the time of their introduction, they have been used for treatment of diabetes. But nowadays they are approved for obesity per se without diabetes, and they are really fruitful. It's supposed to be fruitful because reduction of body weight is reduce the chance of development of diabetes definitely. And if you remember, for example, the use of liraglutide have been used for years and years in a very long-term study called a scale study in patient or in people with impaired fasting glucose or pre-diabetes, and the reduction of the chance of development or transition to diabetes approaches 80%. So it's a very good news.
Yes, it is. So, but can a person use these medications over the counter or under the advice of the experts?
I think using these medications over the counter is not acceptable, although in some countries people can purchase these medications over the counter. I have seen really, but it's not acceptable because there are really some limitations to their use, some contraindications, but these contraindications are not known for the public. They are known for the physicians, particularly experienced physicians in the field of diabetology. So using them over the counter From my side, is not recommended.
Sir, any minimum age for the use of these drugs, or anybody can use for the weight loss?
No, the GLP-1 agonist in general, their use should start just after the age of 18 years.
Okay.
But recently, liraglutide is acceptable at the age of 12 years in pediatrics. It was approved in pediatrics around the age of 12 years.
For weight loss?
For weight loss, yes.
Wow. So it's good news that most of the obese people can use it.
Yeah.
Okay. So as I have started, that there is going to be a great learning for everyone. So I am learning a lot. I am sure the people who will listen this, they will have super learning about diabetes, weight management, hormonal balance for everyone. So nowadays a very common question is, how much walking or exercise is enough for my diabetes? So what do you usually recommend?
The ideal exercise is 150 minutes per week. This exercise is supposed to maintain the weight rather than reduce the weight.
Okay.
But if we plan to reduce the weight, we have to increase the exercise. As you know, the total body expenditure can be divided into basal metabolic rate, thermogenic effect of diet and exercise. So you have to increase your exercise. Sometimes in diabetic patients, we use bone strengthening exercise, walking for example, the use of lifts, for example, just to improve the musculature, because as you know, wasting of the muscles is irreversible. So strength exercise is highly recommended, and sometimes we recommend balance exercise, particularly in elderly.
So like you said, sir, 150 minutes a week. Suppose a person suddenly Monday he thinks today is my workout day and he completes 150 minutes. So rest of the days he can go without exercise, or goal changes?
Probably dividing them is more acceptable. Is better, yes. Probably. I don't know really the exact question, but probably dividing them is better.
30 minutes a day, 5 times a week will also make 150.
Probably, yes.
So walking is, means the diabetics are of different ages. So maybe somebody is having the diabetes at the age of 60, somebody is at the 40, but the same activity is okay for both the age groups, or age group difference is also important?
No, the comorbidities, for example, may be a limitation. For example, an elderly patient with ischemic heart disease, so his exercise have to be tailored to his status.
Okay.
A patient, for an elderly lady, for example, with osteoporosis and visual deterioration, we have to limit her exercise to avoid falls and fractures, for example, because probably she is osteoporotic. So exercise should be tailored according to the status of the patient and his age, his comorbidities. Yes.
So that is what I also like to tell every diabetic person, that if you are diabetic, don't only go by the book. You have to discuss all the things with your doctor, so that you will be knowing what is best for you. There is no one size fits for all. So it has to be individualized thing, rather than there is no common thing which can be used for everyone as a blanket. So regular visit to your doctor, discussion with the doctor is very, very important for each and every diabetic. So going forward, I have lot of questions, because I am meeting so many patients and they have something. So I have collected and thought this is the best time I am getting, so that I can be a help for many diabetic. So sir, what type of exercise do you prefer your patients start with? Walking, resistance training, or home exercises? Just adding one more thing into this, sir.
Yes, walking is used to promote the bone health.
Okay.
Resistance exercise is used to promote the muscular activity. And as I have said, the balance exercise is needed particularly in elderly.
Okay. So many patients are afraid and ask, is it safe for me to exercise if I take insulin or have complications? So how do you guide them on checking sugars and avoiding lows? as there are activities you tell certain patients to avoid or to do only after checkups, like high intensity sports.
Before high intensity sport, the patient is supposed to measure his plasma glucose by his glucometer, and when the plasma glucose is around 100 milligrams per deciliter, the best option is to take few grams of carbohydrate in order not to run the risk of hypoglycemia.
So if a 25-year-old, so it should not happen, but if a 25-year-old suffering with diabetes and is a good player of football, so he should, like you suggested, he should first of all, before every game, he should test his diabetes with his glucometer, take carbohydrate and then go inside the field. So
yes.
Is it absolutely safe for him to play for whole 90 minutes, 100 minutes?
It was variable, something personal, variable, according to the status of the patient, to the type of insulin he is taking, for example, long-acting one, short-acting one, yes.
So there are some devices nowadays, they have come up with which say that continuous glucose monitor. So are they also helpful in diabetic population, especially who are very active or inactive, or for everyone?
Yes, these new devices, if you come across the American Diabetic Association Guidelines 26, they concentrate mainly on devices in these days. Devices are of extreme importance. So continuous glucose monitoring is very useful and fruitful for the patient and for the healthcare provider, particularly in type 1 diabetes, in insulin using type 2 diabetes also, in those people with hectic plasma glucose. Probably these devices are of extreme importance.
So one question for everyone who is seeing this. So do you have an example of a patient who made small realistic activity changes and saw a big improvement in their blood sugars?
Yes, I have seen a good number of patients, they change their lifestyle. I mean, they modify their diet and they increase exercise, particularly walking, and this change in their lifestyle is very fruitful and appealing to me and to my patients, yes.
So
definitely.
sir, if a person does these type of changes, medicines also reduces or withdrawn, or they have to take medicine?
Sometimes we modulate the drugs, particularly sulfonylureas. Probably may reduce the dose, probably.
Okay. So means, like my first question, if a person is diabetic, he has to keep on taking medicine. It should not be withdrawn, but it has to be, doses has to be managed with the regular consultation of the doctor.
Yes, I used to tell my patient that everything is modifiable.
Okay.
A successful drug now is failing the drug after 6 months, for example. The schedule is changing, everything is changing because I think the main player in the management of people with diabetes is the experience of treating physician. You have to know your patient, his lifestyle, his sleeping pattern, everything.
Correct. So sir, coming to the final segment, which talk, so there are patients often say, my life is full of stress. So does this affect my diabetes? How do you explain the link between stress, sleep and blood glucose?
Definitely. Stress has got a major effect on the glycemic control, and I used to see huge number of patients on the same medications, but their HbA1c is coming up. Why? Because they have been exposed to psychological trauma in the preceding month, for example. Death. They are grieved by beloved relative, for example.
Correct.
Yes, it has got a strong impact really on the glycemic control.
Correct. So sir, next what I have seen, especially in Iraq, the use of smoking, shisha and sugary drinks for people with diabetes is very high. And I have seen people just cannot have food without a sugary drink, a cola. And people I have seen, they are saying after food they want to have shisha, because without this they cannot get sleep and all.
Yes.
They are very stressed. So what do you suggest to these type of people?
I think we have to use the media. Yes, the problem is increasing in our country. Smoking is increasing definitely beyond any doubt, particularly in the young generation and even in ladies. We used to see females who used to smoke, but in the preceding years, we haven't seen really.
Correct.
It is not a habit for women, for example. But in these days, we used to see women who are smoking shisha, or this is the traditional smoking. But I used to tell the patients that smoking is going to destroy your vessels, for example. And diabetes is going to destroy your vessels. Lipid is going to destroy your vessels. My task is to reduce plasma glucose, to reduce lipid down to the target in order to protect your vessels. But from your side, stop smoking or reduce smoking in order to protect your vessels. This is your duty and that's my duty. So try your best, just help me.
Correct.
In a friendly way, without any irritation.
So many people tell me that I am not smoking, I am vaping. Vape is not dangerous.
So it is the same trauma. It is the same trauma.
Same trauma.
Yes, yes.
Because I think because of vape, the smoking has increased because it gives the fruity smell.
Probably.
If they traditional smoking, they used to give the bad smell.
Yeah,
But
nasty
this-
smell, yes.
Yeah, but this gives fruity smell. So many people are smoking to look cool.
Definitely, yes.
So one thing which I also feel very important here. So how important is the family support for the diabetic?
It was of extreme importance, particularly in children with type 1 diabetes. The support of the family is very important, particularly from the side of the mother. Regarding type 2 diabetes, from my local experience really, the main supporter for the wife when she developed diabetes is her husband. And the main supporter for the husband is his wife, because people here in our country, women, are really very keen to help their husbands
Correct.
when they become diabetic. So they prepare the ideal diet and they prevent them from taking, for example, simple sugar or refined carbohydrate. So the family support is very essential.
So you are suggesting the lady of the house should be taught what type of food are important
Yeah.
for diabetes management.
Yes, yes.
Fine. So as you have told, sir, in young people, I mean, see, even 15-year-old, you are saying nowadays suffering with diabetes. So how important a role education plays? So do you believe that now these lifestyle diseases management and how to avoid these diseases should be the part of school curriculum?
It may be real part of the school curriculum, or even in the college, at the level of the college and high school. Definitely, sometimes we visit, for example, universities, and we used to tell to gather people and to talk with them. For example, a month ago, I have the chance to go to one of the provinces in Iraq, and I gather people from one of the colleges there, and around 100 students. We talk to them about lifestyle intervention. They have got an impact, those students, on their families, to transfer our experience to them to prevent marked increase in non-communicable disease, particularly obesity.
Okay. So coming to the conclusion, sir, if you could give just 3 simple daily habits for better diabetes control, what should be they?
Number 1, normal sleep.
Okay.
Number 2, reduction of the portions of diet. Because I try to avoid really rigid rules in dietary habits, because people will reject at the end. They will reject. I used to use my plate. Just reduce the portions. Don't worry about the types. Maybe the plate contains different types of food, but reduce the portions. And the third one, I have to stress exercise.
Okay. So the way I summarize it, my learning is portion size is very important. So have the limited portion, reduce carbohydrate. Like sir has just taught me that 7 hours of sleep is also very important, and 150 minutes of weekly exercise. These three, I think, is the mantra for diabetes management, what I have just learned in this discussion. So sir, any message if you want to give to the people who are suffering with diabetes along with these three?
Yes, I advise people with diabetes to ask their physicians to what are the goals. This is very important because we spent years and years in our country and people, they do not know really the goal of treatment, the goals of treatment.
So I'm sure anybody who will listen this interview will have the great learning like I had in this discussion. People who are with diabetes, first of all, we should focus that we should not have diabetes. Like if we can be active, we have limited portion size, and I have just learned the my plate concept. If we apply all this, we can delay the diabetes. And if the person is having diabetes, keep following the tips what Dr. Abbas have given, like 150 minutes exercise every week, 7 hours of sleep, very important, and diet, like you don't have to worry that now you cannot eat because you have diabetes, but you can eat like the way doctor has just suggested us. And if you will keep applying these small tips what he has given to every diabetic, your life will be very good and you can enjoy the life with diabetes. So keep following the tips, keep meeting with your physician regularly so that you can live your life happily ever after. Thank you. Thank you, sir.
Thank you.
Thank you very much for your time. I'm sure everyone will get benefited out of this tips what you have given about diabetes.
Thank you so much. Thank you.
It's a pleasure being with you, sir.
It's my pleasure.